Today we have a fabulous speaker, Dr. Chris Bonafide, whose work I've followed for a long time at Penn. And he's going to speak to us about some of these issues around de-implementation in pediatric settings, and also thinking about how that intersects with work on sustainability as well. I will highlight a few things about Chris. He's a pediatric hospitalist and implementation scientist at Children's Hospital of Philadelphia and the University of Pennsylvania. He completed a general pediatrics fellowship at CHOP and has received training in implementation science and now serves as associate chief for research integration and implementation in the Division of Pediatrics and the associate director for implementation science at Clinical Futures. And he also directs the pediatric implementation research at the Penn Implementation Science Center. And he has several hybrid studies funded in this area. So we are thrilled to have him join us today. And just a reminder, we will be recording this. So I will hand it over. Thanks, Chris.
Awesome. Thanks, Rachel. It's great to be here. I'm excited to see a bunch of you on camera too. It's really fun. I know maybe that will change during the course of the talk, but hi, everyone. Yeah, thanks for the intro, Rachel. I like to kind of start with just talking about my path, because it wasn't necessarily straightforward and probably looks more straightforward on here than it actually was, but I'll try to be realistic. So I'm a pediatrician, as Rachel mentioned, and I work in the hospital taking care of kids on the general pediatric floors. So I did a residency and a chief residency at CHOP. And during that time, I was really interested in thinking about how implementation might be evaluated. I didn't know the language for that at the time. I think this was before, largely a lot of the implementation science movement sort of started. So I was just in this position of being asked to implement a lot of different things, many of which had claims about patient safety, and was just curious how to get started with that. So I just kind of banked that away for a little bit. And I did a fellowship that involved a master's in clinical epi. It was really focused on effectiveness related research. And that was fun. I did some work related to identification of deteriorating kids, but again, kind of still had that lingering question of how do I know that this is the right way to implement this program? I then took a pretty traditional research route, wrote a K award. It didn't have an IS component built into it off the bat, but in the course of that, really got interested in implementation science and ended up taking the Penn course that Renad Batis and Megan Lane-Fall were running at the time in 2015. And that really accelerated and sort of ignited my interest in implementation science. And I got especially interested in de-implementation. And so coming off of that K award, the first bigger grant that I wrote was a UO1 award, and it was really nice. It was focused on preparing for a hybrid trial. That was part of the grant announcement. So it was sort of like a preparatory grant. And what it allowed me to do was really start to understand what needed to be done in order to do a hybrid trial, to write a bigger grant for a hybrid trial. So that was great. And what I'm doing now is I'm really in a super fortunate place to have great collaborators and be working on a lot of implementation science related projects. So the first bullet I'll tell you about in basically the second half of this talk, it's a really fun type 3 hybrid. The second one there is a type 1 hybrid where we really still needed some more information about effectiveness before we could really roll out and focus on the de-implementation there. So I'll mention that briefly later too. And then I also do a lot of mentoring and have a leadership role with the Penn Implementation Science Center. So just a quick snapshot. So jumping right into de-implementation, I know we're all coming from kind of different places, so I like to start just with a general definition here in terms of what de-implementation is. So systematic reduction of ineffective, unproven, harmful, overused, et cetera, health services and practices that are delivered by providers and systems. And we can even, of course, take that out of the health domain too. I know many of you are not necessarily in the health domain, so we can take it out of that as well, sort of overused practices generally. I think what's nice from a clinical researcher perspective is that this is really emerging as a distinct branch and is a research priority for folks who write grants to NIH or PCORI or other federal funders with specific interest at NHLBI, NCI, and increasingly PCORI. So that's just kind of a quick definition. This is the audience participation part. So I would love to hear from you and see your comments in the chat if you have ideas for practices from your world that ought to be de-implemented. Don't worry, there are no wrong answers here. I'm just going to pause my sharing for a second and just listen to you, and also open up the chat in case folks put something there. Oh, Rachel, yeah. Yeah, DARE, the DARE program in schools. Yeah, I grew up, I had a DARE t-shirt. It was like 4th grade. Might still have it. Ineffective school, yeah, school-based mental health services, yep, for sure. So after we have all of these ideas, right? So I think it's pretty common in a situation where maybe you're at a point where you're looking for another grant to write or thinking about a project to do. You might have a list of different things that ought to be implemented or de-implemented. And this framework highlighted on this slide is one that I really like in terms of thinking about prioritizing things that could be or should be de-implemented, and then going forward with making the case for that, and then ultimately going forward and developing and testing de-implementation strategies. So this is a high level view of it. To be honest, we're going to focus mainly on number 1 and number 2 because I think they're the most useful parts of this framework. We'll touch on 3, and then I'm going to refer you elsewhere for 4 and 5. So strength of the evidence is really thinking about what's the case that we can make in terms of the base of the evidence to support de-implementation of a specific practice. And I do like the categorization that Dr. Norton puts forward in this article. So talks about, is this a situation where this practice is proven to be ineffective, where there's strong evidence, compelling evidence that this practice does not achieve the target outcome and may even harm people. So that's not super common that we encounter something that is ineffective and where we also have evidence of harm. But when that is the case, of course, it's a super strong case for devoting resources to de-implementation. We also have, probably more common situations where we might have a medical reversal, where there had maybe been some prior evidence that suggested that something was effective. More recent evidence has gone the other direction. Probably the most common that I see in pediatrics is there's some degree of mixed evidence where there's some evidence that supports the practice. There's other evidence that says maybe the practice actually does not work. So this raises questions about the potential for de-implementation, but maybe doesn't give as compelling a case. And then I think a totally interesting and different area, one that we could probably talk for a long time about too, is what we do with untested interventions, right? So there are plenty of things that we all do, whether it's in healthcare or outside of healthcare, that have never been tested. So we don't know if they have any positive effect or any negative effect. And I think there are questions that can be asked there around, is this something that is an untested practice, one that's can be a prime target for de-implementation? The other thing that I'll mention here that is really important, especially if you're making a case to a funder about de-implementation, is what do the guidelines say? So, if you have evidence that is maybe in the mixed to maybe a little stronger than mixed to support de-implementation, but you also have a guideline that says don't do this, then you can make a much better, much stronger case with a funder about devoting resources and getting funding for de-implementation. So that's strength of the evidence. And then I think magnitude of the problem is the other, I think, really important dimension, that if you're writing a grant proposal to bring into the picture, or if you're more on an operational side and you're interested in making the case for example, a quality improvement project that might involve de-implementing something, these dimensions I think are helpful to call out. So one is prevalence, right? So what's the extent to which this practice is widely used? Is this something that we're doing for 10 patients in the hospital each year? Or is this 1,000 patients in the hospital each year? So what's the prevalence? What's the degree of harm that's happening? So is there actual physical or emotional injury that's happening as a result of receiving this practice? It brings up a colleague of mine has been really focused on thinking about ways that we can really de-implement restraint use in hospitalized kids with psychiatric conditions. So harm is actually a major component of that argument. Equity is very important in thinking about this. So thinking about what's the distribution of the overused practice right now, and then from a demographic standpoint, and then how would we expect that de-implementation would benefit that full range? So is this something where de-implementation is likely to be sort of a one-sided benefit, or is it likely to benefit the full range or the minoritized population specifically? And then resources. So thinking about money, is this a costly intervention? Is this taking up a lot of personnel time or equipment, as well as the opportunity cost associated with not delivering an alternative practice that is shown to be effective? So those are the two, I think, biggest dimensions and most helpful aspects of this framework. I'm going to skip this. The third part is action. So the action is what do we really need to do with this practice? We're not at strategies yet. This is just action. So are we going to completely stop doing this thing? I'm not going to replace it with anything. We're just going to stop it. That's pretty uncommon, that we're just going to stop doing something. And I think there are a number of reasons for that, some of which I'll go over later. But I think the punchline of that is it's really hard to tell people to just stop doing something and not tell them to do something else instead. It sort of goes against our human nature, or perhaps at least our behavior as speaking as a clinician, at least. Replacing is very common. So this is substituting an existing practice with an alternative. And often it's a combination really of these final three bullets. It's, we may be doing a replacement. We may also be reducing the amount of that practice and restricting it to a narrower population or a narrower setting. So, for example, there might be a practice that's a really great fit for the intensive care unit, but perhaps is being overused outside the intensive care unit on general care floors or even in the outpatient setting. And so in that situation, there might be a de-implementation that's focused on a particular setting. It's not that the practice itself is ineffective. It's when the practice is applied to a certain context or population that it's not benefiting that target group. So those are the first 3 points. I'm going to show you the way that I usually approach barriers and facilitators and strategies, which is not necessarily strictly according to this framework. And I think there are better options for framing that. The way I really like at least going about selecting de-implementation strategies is to use a process called implementation mapping. That's relatively new. This article on the left is just from 2019. And then the article on the right by Katie Hoskins and others at Penn is more recent than that, 2022. And I just find that article on the right by Hoskins to be just a really awesome example that walks through the process of implementation mapping in a way that is, really rich with examples and feels very practical. So I'll show that at a high level. I'm not going to go through implementation mapping in a lot of detail because we could do that for a long time, but I do have an example when I talk about our type 3 hybrid trial where I'll go into a bit of detail about it. But the high level view is in the first step, you're really doing a needs assessment. So really seeking to really understand what's going on with the practice, hitting on those issues around magnitude of the problem and impacts of the problem, and then understanding what the barriers might be to, in this case, de-implementation. In step 2, you're really fleshing out a logic model where you're really trying to have a high level sense of what those barriers are that you learned about in step 1, and starting to understand almost like a menu of potential strategies that could be used in this context, and trying to identify what some of those mechanisms might be that would inform and impact your ultimate de-implementation process. And then I will go through one by one each of the parts of step 3, but this is really where you take those ideas for strategies and start to more closely connect them to what you learned in step 1, sort of that process of taking, okay, this is a key barrier that we identified. Now we're going to look and see, okay, of these potential strategies, based on what we know from these particular theoretical foundations, this is a strategy that we may link to that particular barrier, engaged with stakeholders, of course, through that process. And then in step 4 and 5, you're basically saying, okay, these are the strategies that seem to be rising to the top. Let's flesh out what it means to do audit and feedback on the pediatric floor for this particular problem. What does that look like? How does that look from a sort of protocolized standpoint? And then in step 5, you're testing. So that's a really high level view of what that looks like. And again, I'll give you an example in a few minutes. So I wanted to bring in one, there aren't a lot of super helpful de-implementation focused frameworks. This is one that I really liked and worked into at least one recent grant. This is by Christian Helfrich. And so what this helped me with was really thinking about what are some ways that we need to maybe think a little bit differently about picking strategies for de-implementation in a way that's a little bit distinct from implementation. And again, this is like a pretty young field, but what this really helped me with was thinking about these two almost like groups of strategies that can exist to support de-implementation. This was modeled after like the dual process model. So I think of that like the thinking fast and slow kind of paradigm. So the first part is unlearning. So really this is thinking about how we can tap into clinicians' slow or reflective type 2 thinking. So getting them to really reflect on this problem, what they're about to do, and have a moment of saying, you know what, I'm actually not going to do that. So examples of strategies that might tap into unlearning might be some basic educational outreach that's emphasizing what we know about the evidence, what we know about the guidelines. Audit and feedback might also be a strategy that taps into unlearning. Or champions, folks who are going to be physically around and can help in the moment to with that decision making about whether or not to use a strategy or to use a practice. You can imagine, though, that especially in a busy hospital clinical setting where I work, there might not be a ton of slow, reflective thinking that's happening in those moments around, should I use this particular practice or not? So that's where this second category comes in of substitution. And of course, this links back to the Wynne-Norton framework too. And here, what we're trying to do is build substitution into systems so that the environmental cues and increasingly we're thinking about that in the electronic health record. How can we change cues there to really drive behavior against the practice that we're trying to de-implement and towards an appropriate substitution? So I'm going to touch briefly on outcomes, really focusing on, and strategies, really focusing on what's different between existing published literature around implementation focused stuff. So this paper that's up in the upper right here was a helpful way to sort of start to think about how we might start with the sort of primary paper around implementation outcomes by Enola Proctor, and think about how definitions for some of these outcomes might be different for de-implementation. And so what this paper does is it points out what some of those subtle differences might be, and really focuses on, okay, in addition to measuring outcomes of the targeted practice, make sure we're also looking at outcomes related to the de-implementation process. So this was a paper that I found helpful when explaining to potential funders how we're thinking about these outcomes different from in implementation. And there's an example here, which I won't read out loud, but with using penetration as an outcome and how it differs between the original Proctor definition and then how it's written up for de-implementation. So I'm going to move now into a practical application. So EMO, the Eliminating Monitor Overuse trial, is one that I'm leading now. We're going into our third year of the trial now, and it's co-led by myself and Renat Betis. So the topic of EMO is the de-implementation of continuous pulse oximetry monitoring in kids with bronchiolitis who are not requiring supplemental oxygen. And I'm going to give some clinical definitions in a second so that we can all kind of get on the same page. We're doing this trial in a network called the PRISE network, which is it's a network of about 115 hospitals, each of which has a very clinically oriented site lead who's willing and interested to do multi-center research, and it's in the US and Canada. So bronchiolitis is a really common lung disease of kids exclusively under 2 years old, or vast majority under 2 years old. And it's caused by a viral infection, most commonly RSV, or the respiratory syncytial virus. It's the leading reason that babies are hospitalized, second only to being born. So it causes about 100,000 admissions annually. The good news is that care is mainly supportive, and mortality is exceedingly rare in bronchiolitis, which is great. It's also very seasonal, with pandemic times excluded when viruses did really weird things, but traditionally is super seasonal, which has implications for the trial design, with almost all the cases occurring in the winter months between November and the end of March. So I'm not going to go in depth about the evidence, but I will highlight that we do have 3 sets of national guidelines that are supported by clinical trials that discourage the use of continuous pulse oximetry in kids with bronchiolitis who are not needing oxygen, because monitoring with pulse oximetry is ineffective during those times, does not improve outcomes, and has other downsides such as alarm fatigue, and other issues like prolonging the length of hospital stay. So that's kind of a foundational thing, is this type of monitoring continuously, meaning putting the monitor on the baby and leaving it on for long periods of time, is the practice that we're trying to change. We did think about different types of hybrid trials as we were putting this grant together. And there can be, among implementation science folks, really vigorous debates over, what type of trial should this be? What type of hybrid trial should this be? So many of you, I'm sure, are familiar with hybrids. I'm sure that some are also not, so I'll mention them briefly. So a hybrid type 1 is when you have something that is maybe you think is potentially a good candidate for implementation or de-implementation, but the evidence to support that as a standalone like implementation trial isn't there yet. So in a hybrid type 1, what you're mainly looking to do is test the effectiveness of a practice, while you're also looking at some of the implementation factors. So you might be measuring some implementation outcomes like feasibility or acceptability. Maybe you're doing some of that foundational work around looking at barriers and facilitators to subsequent large-scale implementation or de-implementation. On the other end of the spectrum is a hybrid type 3, and that's what this EMO trial is. And in this, you convince the funders that, look, this is a practice that is ready for de-implementation or implementation. And in doing so, you're designing an experiment that's not about the effectiveness. So in this, we're not trying to show whether or not pulse oximetry continuously is effective or ineffective. That's already been done. So what we're really trying to do is figure out what's the right way to apply strategies that will promote de-implementation on a large scale. So we're still measuring clinical outcomes as indicated in that middle box, but But really what we're focused on are the implementation outcomes, and that's what we're powering the trial on. Hybrid type 2s are in the middle and are challenging because you're really equally weighting implementation and clinical outcomes. So we're doing this as a type 3. So I'll walk through it, and in some degree, this is going to mirror or should in part at least mirror some of the different steps that I outlined before related to implementation mapping. So when we got started with this, we really didn't know how much overuse relative to those guidelines was happening across the country. And in part, that's because we weren't able to measure it using databases. So one of the things about monitoring is that it's not like giving a medicine where there's a great audit trail of, physician places an order, a pharmacist prepares the medicine, delivers it to the floor, a nurse administers the medicine. With monitoring, it's kind of the Wild West where I might order it. It might not get put on the patient because there's a good amount of nursing practice discretion that can happen there. So there might be an order and monitoring not occurring. There might not be an order and a decision at the bedside to put a monitor on a patient. So really, there's not a great way using the electronic health record or administrative data to sort out who's monitored and when. So what we had to do is we had to have people walking around in a bunch of hospitals and just looking to see what monitoring was happening on these patients. So this figure is from our first project where we had folks at, this shows 49 hospitals who were walking around to see amongst kids who met guidelines to be unmonitored, where guidelines said these kids should not be continuously monitored, how often was that happening? So the y-axis is the percent of those kids who were continuously monitored, essentially like against guidelines. And you can imagine how if folks were following the guidelines to the letter, that would probably be 0. And we sort of course, will accept a good amount of clinical discretion. There may be some kids that have other circumstances that warrant continuous monitoring. So maybe, I don't know, 0 to 20% would be reasonable in that paradigm. But what you see is that it's extending all the way from about 5%, up to more than 80% of these kids being monitored. So this was helpful in the sense that we knew that, number one, it was possible because we did have these hospitals all the way to the left that were monitoring very few of these kids. But we also knew that we could probably learn a lot about barriers from the hospitals that are up to the right. So what we did next was we talked to people. So we conducted interviews of folks in a number of different professional roles related to monitoring at those hospitals to ask them, for the folks in the lower left, like, clearly you've put some effort into this if you're not monitoring these kids, what was working for you? And for the box in the upper right, really saying, hey, is this something that you guys have tried to do before, tried to de-implement before, but hit some barriers, and if so, what were they? So that was really insightful, and we took the findings from that and really did some of those sort of middle processes in that implementation mapping diagram in person across 2 different sessions in early 2020, right before the pandemic hit. So this is where we did things like did that mapping between barriers and potential strategies, wrote out those specifications for the potential strategies that we were thinking about applying, and really took steps that we thought were needed to begin to operationalize those strategies. So what do we find? This is obviously a very, very shortened version of what we found in that process, but where we landed on was we had some things that we put in a bucket of unlearning. These were things that were very commonly used in quality improvement collaboratives in hospital medicine, and considered those sort of what we would probably consider part of the usual approach. These were things like bringing on champions, educational initiatives, and a couple of different types of audit and feedback that we discussed. And then there was a lot of interest and excitement in the potential for having a clinical pathway that was built into the electronic health record as something that would help with that substitution process. So basically saying, okay, instead of using continuous pulse oximetry, just check it periodically, every 2 hours, every 4 hours. So we call those spot checks. So that's what sort of came out of that process. We then wanted to understand a little bit more about feasibility and could we change practice. This was a really short-term feasibility pilot trial, so we didn't have time really to do anything with electronic health records in terms of building new CDS or clinical decision support. So this trial just applied educational outreach and 2 levels of audit and feedback, one that was delivered sort of in the moment and one that was delivered on a weekly sort of aggregate basis. And so we had 6 hospitals. The middle column is how many of those patients were monitored at baseline. So assuming that at least to the letter of the guidelines, those numbers should be 0, maybe allowing a little bit of leeway there up to maybe 20%. This is where they were starting. So anywhere from 23% to 79%. And then you can see how in each, we actually had a pretty nice drop in monitoring, even for the hospital that started at 23%. So with an overall adjusted pre-post difference of a drop of 31 percentage points. So this was really helpful in really saying, okay, this is doable, even with what we're considering our foundational baseline strategies. So that was helpful. So that was the end of that initial set of projects, that initial first grant. But what really got us curious was thinking about sustainment. So what we knew from lots of other examples was that sometimes when you withdraw these pretty time and personnel intensive strategies, stuff goes right back to the way it was and can happen real quickly. This is not my project and has nothing to do with pulse oximetry. It has to do with antibiotic prescribing, sort of unnecessary antibiotic prescribing. And so what you see in the intervention group here, the orange dots, as soon as that blue intervention period stopped, that just really predictably and smoothly, that practice went right back to the way it was before. So this made us concerned and worried and got us really thinking about sustainment. So we also had to ask the question of what is sustainment, right? So in the implementation science literature, it's often called sustainability. And so we started just like, what's the definition? So we looked at that de-implementation focused paper. So thinking about it, so this is how they define it: the extent to which a practice's discontinuation is maintained. And then give this example of how many folks are still no longer doing the thing that they're not supposed to be doing after some period of time. So we said, okay, there are some things that we can take from this. One is it's pretty clear that sustainment has to do with what's happening after you stop doing the strategies. And then, maybe an unclear washout period there, but we need to wait. So after the strategy is stopped, we need to wait and we need to sort of remeasure after that. So that was helpful. And then we sort of started playing around with pen and paper and saying, okay, like, what is sustainment? Do we know it when we see it? And what are some of the different ways it might look? So this is just like what we did at the time in terms of drawing this out. This was sort of what we said was like the most classic phenotype of sustainment, right? So you have a baseline period where people are doing too much of something. You apply some de-implementation strategies, and that decreases use of this thing that we're not supposed to be doing. Then there's some washout period. And as long as that is maintained about the same level, then that's sustainment. But so that was, I think that was pretty easy to agree on. I think where it got complicated is that there are different things that can happen, right? So this might be, okay, doing too much of the thing, do a lot of strategies, and then things keep going down. Is that sustainment? Maybe it is, but it's sort of maybe suggest that there was something about those strategies that persisted in a way that continued to chip away at the problem. I think we could agree that this was not sustainment. So this is where we clearly have some rebound happening afterwards, right? So this I think we've said, okay, we want to make sure we don't accidentally call that pattern sustainment. This one's a little weird, right? So we were doing too much of the thing. We actually didn't impact it straight away, and then things started to decrease again. So is that sustainment or something else? Another interesting pattern that we wanted to be able to detect, right? So baseline period, doing too much of it, the strategies had no immediate effect, but then something happened during that washout period that led to that sustainment to dropping below original baseline. So I'm highlighting this because I think there are different ways that the data can be analyzed that will pick up on some of those, but not all of those. So I'm gonna do a rundown of that in a minute or two. But before I do that, I want to show you how we designed the EMO trial to be able to really focus on sustainment. So this entire trial is focused on the primary outcome of sustainment. So what we did in phase 1 was we had a baseline phase where we measured the amount of overuse that was happening across all hospitals. We did this in 50 hospitals. And we did this before randomization because what we knew, at least what we suspected, was we would find some hospitals that had already solved the problem, that weren't overusing pulse oximetry. And we didn't want to commit them to a 3-year trial if they were only monitoring 10% of these kids at baseline. So we had this run-in period with 50 hospitals here. We then excluded hospitals who either had that issue where they had already solved the problem or just had real feasibility challenges. I mean, we were starting this towards the tail end of the pandemic, right? So it was a weird time. We didn't know what we were going to get. We didn't know if hospitals were going to be totally slammed with clinical needs. We also didn't know if bronchiolitis was going to be a thing because of how much the pandemic affected sort of normal viral seasonality. So we certainly over-recruited here in a good way. We then randomized 38, which was part of the original plan. And then we applied strategies. So in phase 2, we did educational outreach and audit feedback in one arm. And then the experiment was continuing to do educational and audit and feedback in the other arm, but adding clinical decision support in the electronic health record. And that's because the hypothesis here was that decision support in the electronic health record will persist through the washout period and lead to greater institutionalization, so building this practice into existing institutional structures, and more routinization, so building this practice into people's everyday routines. So that's the experiment here. And then after phase 2, we withdraw the education, audit, and feedback from both arms, so that only the decision support persists into phase 3, and then we measure sustainment in phase 3. And that's where we are. We're starting phase 3 in December. I mentioned this is just another way to look at it, and I'll show you how this shows how we're sort of primarily analyzing it, but we have 2 other analytic approaches that we're using. So again, incremental benefit of electronic health record decision support, adding to the education and the audit and feedback. And this is what we put in the grant as what we would hypothesize would happen. We thought we'd start around 50%. Both arms would drop pretty symmetrically. We didn't anticipate a big difference between the 2 arms because of the power primarily of audit and feedback and changing behavior. That's sort of known in the literature. But what we thought would happen is that there would be a bigger rebound, basically a sharper, more acute angle in the arm that just got the education audit feedback compared to the arm that also got decision support. I mentioned that. So the first measure that we planned for sustainment is a diff in diff. So we said we're going to compare where they started and where they ended between arms. And that's relatively easy to design for an analysis, and it's relatively easy to power on. But then we went back and we looked at all of those graphs that I showed you that are now to the right. So first 2, cool. It'll pick up those 2. Won't pick up this one, which is good. We don't want it to pick up that one. It would also pick up these 2. So we wanted to just sort of think about, okay, maybe that's fine for our primary analysis, but let's make sure we're also doing a couple of other things to look at sustainment. So we came across this other article that was a nice kind of review paper that looked at sustainment. And so what they proposed was, okay, what we need to do is maintain at least 90% adherence in order to call something sustained. So that was interesting. So we said, okay, how would we do that? So we did some calculations to do that. So an example might be a hospital that goes from 50% overuse in phase 1 to 30% in phase 2. So, again, to the letter of this guideline, which is focused on adherence to a guideline as opposed to non-adherence, we flipped it. So we said, if we calculate 30% overuse would be the same as 70% adherence to a guideline. So 90% adherence would be 63% adherence to a guideline, which would be 37% overuse. So we said, okay, well, so what we would do in a situation where a hospital went from 50% overuse to 30% is we would say, okay, as long as they didn't bump up above 37%, then that would be considered okay, it was sustained. That was okay. We were sort of lukewarm on that one. I think what it does is it kicks out some of these other shapes that we were kind of uncertain about, right? Specifically these two that were not kicked out in the prior. But it still felt a little imprecise. So we came up with this third way that we're excited to use. So this one is actually focused much more on the slope between phase 2 and phase 3. So here, what we're saying is, okay, among only the hospitals that did have a drop between phase 1 and phase 2. So we're saying, okay, between in phase 1, they were overusing. In phase 2, they had an improvement with those really intensive, personnel intensive de-implementation strategies. And then what we're looking for is that slope between phase 2 and phase 3. So the slope that happens during that washout period. And the way we're framing this is if that slope is significantly greater than 0, meaning it has a significant uptick, based on statistical testing, then de-implementation is not sustained. So what that looks like here is it would give credit to these first two options, would not give credit to the subsequent 3, and does so with, I think, a more precise measurement and way to get an easy statistical test. So that's that. So where we are right now in the trial is this is what we have so far. So this is what was planned, and what we have is quite similar, just a little bit above. So really, that's cool, but where the magic will happen is what happens in the next phase. So we're really eagerly awaiting the start of phase 3 when we'll be able to measure this and see what happens. I'm gonna jump to one more thing related to outcomes for about 2 minutes, and we'll stop. So we're measuring a lot of things in emo, and I won't go through each of these, but one more that I'm really excited about that's related to de-implementation is this thing called psychological reactance. This is something that we just kind of stumbled on. I don't remember how we. I remember how we originally got to it. This is mentioned in that Christian Helfrich framework that I showed earlier that had unlearning and substitution. This sort of mentioned casually in there as something to think about in de-implementation, and we really latched onto it as something that we thought was interesting. So, psychological reactance is thought to be a potential moderator of strategy effect. When we're thinking about things like adoption, penetration, and sustainment. And it has a number of different constructs. So it has, one of the constructs that I think is really interesting is called freedom threat. So the idea here in emo is that nurses have a certain scope of practice, right? Like putting kids on monitors is totally within that scope of practice. And you could think of that as some degree of freedom to decide what they're doing for their patients and make those decisions without orders or input from physicians. That's totally an okay thing to do. And so now with us coming in and saying, look, this is the new way we're going to do things. We're actually, instead of using continuous monitoring, we're going to use this instead. We were concerned that there could be some reaction to that. That could include feelings of anger or at least negative other forms of negative cognition, changes in attitude, that kind of stuff. So we did a fair amount of work to understand how this can be measured, and it was really like in the communication literature, and ultimately the way we decided to measure it was this is a poster that we used that we was sort of posted in all of the participating hospitals that had a lot of different information about this new initiative to de-implement continuous pulse ox. And then we just asked people, according to existing validated questionnaires for these, what their reactions were to the poster and the messages in the poster. So it was really interesting and was relatively easy to do. On the positive side, we really didn't get much in terms of negative feedback at all on that poster, which in some ways is good, in other ways is a little bit less scientifically interesting. So You can see down here, like for freedom threat, really it's just a small proportion of folks. We get maybe almost 5% here saying that the poster like tried to make a decision for me, tried to pressure me. So there's a little bit there. We're interested to start looking at this across disciplines, because one thing we knew from our pilot was that the perception of safety is much different in nurses and physicians when it comes to monitoring. So we're continuing to look into this more, but I wanted to share it because I think it's kind of an interesting aspect of this implementation work. So I'm going to stop here. Thank you for your attention.
Awesome. Thank you so much. This was fascinating. And I mean, my mind is being blown with the connections between the de-implementation and sustainability part that I had never made a lot of those connections. And the scale at which you all are doing this is really impressive too. Or thank you so